This is a video on Kasai Porto Enterostomy. The child is a 75-day-old girl who has presented with neonatal jaundice and clay-colored stools since 2 weeks of life. The skin and the eyes were yellow since 25 days of life. She was preterm and on clinical examination, along with hepatosplenomegaly, also has an umbilical hernia. The investigations show a normal CBC and raised liver functions, direct jaundice with raised enzymes. The torch titers were negative and 2D echo is normal. Ultrasound scan showed a distended gallbladder, and a gallbladder that is distended does not preclude a biliary atresia. Here you can see the triangular cord sign marked between the yellow dots, and in subsequent picture one can see a large hepatic artery with a portal vein. Generally children with biliary atresias have large hepatic arteries. We do an X-ray spine to confirm butterfly vertebrae, which was not seen in this patient. The child was anesthetized by general anesthesia and kept in a supine position. Parts were painted, prepared and draped. The position was with a bolster below the upper abdomen. So a small incision was marked in the subcostal region and deepened to look at the gallbladder, which was aspirated and showed clear bile. So there was no need for intraoperative cholangiogram, and the incision was extended on medial and lateral aspects. This is the ligamentum teres being cut between two clamps to expose the liver. So as the liver is exposed, there is inspection of the gallbladder and the rest of the organs. We can see two splenunculi, one large, one small in the hilum of the spleen. The cecum was inspected to rule out malrotation. The small bowel was checked for Meckel's diverticulum and malrotation was ruled out. So now we are mobilizing the liver. This is the falciform ligament being cut with a micropoint diathermy to get the liver out of the abdomen. The dissection proceeds until the hepatic veins. This is the left triangular ligament that is cut, and this is the right triangular ligament. So after mobilizing the ligaments of the liver is taken out to expose the undersurface of the liver. So then the abdomen is inspected, and you can see the gallbladder which is collapsed. A stay suture with 3-0 Mersilk is taken and gallbladder is mobilized. Then the dissection proceeds to the region of the bile duct, and here we are separating the peritoneum and dissecting the hepatic artery. The bile duct then is looped and ligated between two sutures. Bile duct is transected. This is the cystic artery which is taken care of, and then the extrahepatic bile ductular structures which are obliterated are lifted off from the vessels. So that's the portal vein that we are separating and the hepatic artery. And at the top of the portal vein, the bifurcation, one has to be very careful of small venules that run from the portal vein to the undersurface of the liver, because if these bleed, they can create problems. So these have to be meticulously taken care of, and then the extrahepatic biliary tree is seen. That's the gallbladder with the bile duct, and that's the right hepatic artery, the left hepatic artery, and the middle hepatic artery. Now here there is an additional abnormal middle hepatic artery as well. So sometimes these middle hepatic arteries create issues for dissecting the left portal plate. So sometimes they may need transection, but here we have decided to keep it. A portal dissection is done by Kasai scissors. This scissors has an angle of about 135 degrees, and that helps in dissecting the portal plate from the undersurface of the liver. Now, as you can see here, that the dissection is done outside the Glisson's capsule and the entire extrahepatic tissue is carefully dissected off without getting into the liver substance or liver parenchyma. Posteriorly, where there is a fibrous margin that bleeds a lot, but one has to be careful of not utilizing the bipolar or the diathermy around this area. Simple pressure will take care of the hemostasis. And one can see the posterior rim and dissection is proceeded onto the left side of the portal plate. Now a traction has made the gallbladder get avulsed because we have to do an extended dissection onto the left side. So this is the portal plate that has been dissected off. That's the posterior margin of the fibrous tissue. A liver biopsy, a wedge liver biopsy is undertaken and hemostasis is used by bipolar cautery. Now a roux loop has to be fashioned. The second loop from the DJ is identified, which could be mobilized easily up to the undersurface of the liver. It's devascularized and the loop is transected using a monopolar cautery. The exposed ends are doused with dilute betadine swabs, and then the roux loop is closed at the end in 2 layers, 50 vicryl. Then a retrocolic window is made and the loop is taken up to portal plate. So the loop is opened up and the portal reconstruction, the Porto Enterostomy, is begun. So here one can take the sequential sutures and keep them long on a ligature rider or ligature carrier, which is unfortunately not seen in this picture. And we tend to keep all the loops long and sequential and then tie them at the end. So this is the usual protocol that we follow. So the sutures are taken from the posterior wall of the opening made in the roux loop to the inferior fibrous margin of the portal plate. And on the left side, one tends to go in an extended fashion, pushing the middle hepatic artery and the left hepatic artery towards the left side, so we can do an extended Porto Enterostomy. As you can see, all the ends are kept long and tied together. In the picture, one can see operating loops. So generally, a 2.5 magnifying loops are used for doing a Porto Enterostomy, and these serve in good stead for such fine work. So that's one of the end stitches for the posterior wall, and then we make the loop ride on all the sutures to come towards the portal plate, as you will see now. So that's the way the loop is ridden and brought to the portal plate, and then sequentially one by one the sutures are tied off. The first suture is kept long with an artery forceps and the rest are clipped. Then we close the anterior wall to complete the Porto Enterostomy. So on the medial and the lateral aspect, a suture is taken just to support the anastomosis. Now the place from where the loop comes out in the mesocolon is sutured off and the liver is reposited back to the abdomen. Now 40 centimeters loop distally is measured off for the lower anastomosis, which would be the end to side anastomosis. So this is the place where the lower anastomosis is fashioned. The jejunum is opened on the antimesenteric side, and the end of the proximal side is anastomosed here in a single layer fashion using 50 vicryl. Once the anastomosis is complete, the mesentery is also closed to prevent internal herniations. And then we check for the patency and that there is no leakage from the anastomosis. This child incidentally also had an umbilical hernia which was taken care of from the intra-abdominal region. So the sac is excised and the hernial opening is then closed in layers. The abdominal cavity is washed with plain warm saline and the intestines are reposited back into the abdominal cavity. Liver is reposited, falciform ligament is closed, a drain is inserted in the right iliac fossa, a tube drain which is fixed with 3-0 Mersilk, and then the abdomen is closed in layers. So this is a peritoneum which is closed by 5-0 Vicryl in a continuous fashion. This is followed by muscles which are closed with 3-0 Vicryl in an interrupted fashion. And then the subcutaneous and the skin are closed with 5-0 Vicryl. Skin is closed in a subcuticular manner. An appropriate dressing is given. And the child is shifted to PICU for monitoring. This is a follow-up after 1 month where the eyes are white and the scar is healed. Thank you.